I'm Ty Fowler. I'm an orthopedic trauma surgeon and specializing in the hip and pelvis. I also do hip reconstruction and quite a bit of anterior approach total hips as well. So doing a talk on hip pain, especially this talk, patients can be pretty painful, and there's really a tough thing to diagnose a lot of times because of the amount of etiologies that can take place that can cause so much confusion around hip pain, but we'll kind of get into it a little bit here. So low back, the actual hip joint, soft tissue structures around the hip, nerves, all of those things can really cause hip pain, which can really just create a lot of confusion for both practitioners as well as the patient. And from the patient side of things, right, the one thing that's really difficult that I've come to realize is most patients have no idea where their hip is. The number of people that grab their back and say my hip is killing me astounds me still to this day, but that is real. And at any rate, you know, this is just kind of an example of all these different etiologies that can cause, you know, hip pain in that global area, and having an algorithm to try to really come up with a good way to get a good differential diagnosis and try to get down to the accurate diagnosis can be extremely helpful in a very confusing subject. So the way that I like to think about this whole algorithm is basically break this down into anterior, lateral, and posterior. So after you ask the patient, where do you hurt, and they look at you like you're silly, I just told you it's my hip, and they're pointing up here, I literally will say, use your finger and show me where it is, because of that fact. And if they're pointing to the front, the side, or the back, it already kind of sends you down that algorithm that you can kind of start to focus in on what exactly the diagnosis is. So again, really just anterior, lateral, posterior, pretty simple. So we're going to start with anterior hip pain. So a patient points to the front of his hip, and really what we're also talking about in the history that's important is to try to figure out, is this more of an insidious onset type of pain, or is it more related to sports, an acute process, overuse, and related to activity? But anterior hip pain can generally be broken down into three things: pathology of the actual hip joint, the intra-articular space, which we'll go through that, hip flexor strains, we'll go through that as well, and iliopsoas bursitis. So focusing on the intra-articular hip joint, this is an area where an x-ray can, number one, give you a lot of information about what a patient's feeling. But starting off, and the majority of people that have anterior hip pain and groin pain are patients with arthritis. And you can see in the x-ray there that the joint space is fairly narrowed. These patients are going to come in with a complaint of losing motion. Right? They're gonna complain that for some reason their foot's all of a sudden starting to point externally. They just can't control it. They have troubles donning their shoes and socks. All of those things are going to basically play into a patient with arthritis. That's how they're going to present. FAI, which we're going to have a talk about coming up here, femoroacetabular impingement or hip impingement, coordinating that with a labral tear. This type of patient is oftentimes younger than the arthritic patient, more active than the arthritic patient. They do not have a loss of motion. Conversely, they will oftentimes say, yeah, I've been inflexible my whole life, but it's not over the last 2 years. My motion gets worse and worse and worse. They can't sit for long periods of time. And obviously on physical exam, you know, a hip impingement test where the leg is flexed, internally rotated, and adducted oftentimes will cause quite a bit of pain. Dysplasia is another common hip problem where people will be complaining of anterior groin pain or hip pain. These people oftentimes will produce a C sign, and again, I won't get too much into it. Dr. Ellis is going to talk about it, but you know, C sign is when somebody basically says, where do you hurt? They grab their hip like that. Oftentimes people with dysplasia will do that, but clearly you can see on the left where it's dysplastic compared to the right. There's a lot of uncovering of that femoral head, starting to sublux laterally, and that joint ultimately is going to wear out here pretty quick. But next is avascular necrosis. Now these people have anterior hip pain, thigh pain, groin pain, but they oftentimes will have a history of heavy alcohol abuse, oral steroids, I see a lot of AVN in HIV patients. There's something about antiretrovirals that has a propensity to cause avascular necrosis. And again, MRI is very helpful with AVN. And then lastly, fracture, right? This is an X-ray of obviously a completely displaced fracture. Not too many times you're going to see this in the office. It does happen every once in a while, but this is related more to a specific traumatic injury or fall. The one that's a little bit harder is the stress fracture patient. So in people, you really want to pay attention to history. Have they picked up on an exercise regimen and really going after it hard, which is kind of new for them? That's oftentimes can be related to stress fractures. And then we always have to be aware of the young female runner, amenorrheic, oftentimes will have low bone mineral density as a result of, oftentimes an eating disorder. They're at a really high risk of developing a stress fracture as well. And again, sometimes you can see it on X-ray, most times you can't, and an MRI can be helpful. So moving on, hip flexor strains. This is going to be more related to an acute onset. Usually patients know when the injury happened. There's some kind of incident that says, yeah, I was doing this and started having pain. It's often in athletes, but these people in physical exam will have pain with resisted muscle testing, as well as tenderness in the muscles. So the main hip flexors are your tensor fascia lata, your iliopsoas, and rectus muscles. And then finally, iliopsoas bursitis. This is a little bit more of a slower process, not necessarily an acute onset injury, but it can be related to sports and overuse injuries. But these people will sometimes complain of snapping and popping in the hip as well. Sometimes they can actually reproduce it for you in the office. But a test that you can do, an iliopsoas snapping sign, where you flex the hip, externally rotate, and abduct the leg. That's your starting position. And what that does, as you can see in A, is take that iliopsoas muscle and put it over on the lateral side of the femoral head, the ball of the hip socket. And as you take that leg and extend it down and internally rotate it, sometimes that iliopsoas, if there's a lot of inflammation, will literally snap over the top of the femoral head and can cause a pop. It can be audible sometimes. It's usually painful. So that kind of sums up more or less the anterior hip pain, generally speaking, right? Hip joint, hip flexor strains, and iliopsoas. Moving on to lateral pain. Greater trochanteric pain syndrome oftentimes encompasses both bursitis and abductor tears. Iliotibial band syndrome can be included in that as well. And I put neuralgia paresthetica in the lateral hip pain as well. So starting off with trochanteric bursitis. Just a good history reveals that patients are painful directly lateral. This can radiate down the leg, but it usually never goes past the knee. It can cause pain and tenderness down by the knee too, but mainly it's right up around the trochanteric region. These people will specifically say, I cannot sleep on my side. I can't sleep on that affected side, because they're basically putting all of their body weight directly onto that inflamed bursa. It's oftentimes more common in women. Women have wider hips, which is going to put more tension on the IT band and predispose them to be having bursitis, more common than men. And again, physical exam, these people are tender directly over the bursa right there in the trochanter. Abductor tendinopathy tear. So in a lot of times people, so Bird in 2001 did a study where they looked at resistant bursitis, injections, anti-inflammatory medications, things just aren't working. It just keeps coming back. They did MRIs in these patients and found that almost half of them had tears of the abductor musculature. The way that you can differentiate bursitis and abductor tears is usually a physical exam, but oftentimes needing an MRI to really prove it. But these people have pain with resisted abduction, and weakness can be more prominent in somebody that has an abductor tear compared to just bursitis. You can have weakness in testing the abductors with bursitis. It's usually related to pain, but again, with the leg abducted, that relaxes that IT band and oftentimes doesn't produce the bursitis pain and more of the representing the pain of the abductor tears. So iliotibial band syndrome, it's really similar to bursitis. One of the differences is people can have snapping on the lateral side of their hip. So people that have really inflamed tight iliotibial bands, it's usually in athletes and runners. And this also can extend down the knee. But realistically, I have a lot of people with iliotibial band syndrome that will say, oh, willy-nilly, right? Oh yeah, I can dislocate my hip. I can pop it back in. We know they're not dislocating their hip, right? All that's happening is that IT band is snapping over top of the trochanter, but it can be pretty impressive to the point where it can jolt your pelvis around. It can be loud. You can visually see it as well as hear it. And then finally, the myalgia paresthetica. So I threw it in here because about 25% of people will complain of direct lateral pain with this, and this is oftentimes related to the anomalous course of the LFCN. And there was a recent study sometime in the last 6 months or a year in Journal of Bone and Joint Surgery that looked at a cadaveric dissection of the LFCN and showed that there's about 3 different variations. And one of the variations is there's a far posterior branch to this nerve which extends down onto the lateral side. But typically this pain is not as much tender as it is just pain. It's more of a nerve type of pain. Numbness, they can have burning sensation. They'll have a positive Tinel sign, and where you test for that is right at the inguinal canal and the inguinal ligament where it meets the ASIS, so the pelvis. And oftentimes, you know, people who are obese, diabetic, pregnant females are going to be at more of a risk of developing myalgia paresthetica, but it's essentially a kinking of that lateral femoral cutaneous nerve. Weakness is not associated with this, right? This is a cutaneous sensory nerve only. So that kind of sums up lateral hip pain, greater trochanteric pain syndrome, iliotibial band, and myalgia paresthetica. And then finally, posterior hip pain. Low back pathology is a common etiology of people who come in complaining of buttock pain or hip pain, that they're basically grabbing their backside. SI joint pathology, and really sacral stress fracture should be included in this section as well. And again, external rotator or piriformis syndrome pathology can cause a lot of buttock pain. So getting into it, lumbar disc herniations with radiculopathy. So a lot of times back pain is associated with a complaint of buttock pain. It doesn't have to be long-standing back pain. The annulus of the disc is richly innervated with nerves. And oftentimes when people, you know, have the history of throwing out their back, dramatic back pain, they can't get off the couch for a day or two, it's usually related to that annulus tearing. And then following that, they start developing buttock pain and potentially a radicular pain that can radiate down the leg and oftentimes even well past the knee. When something radiates past the knee, that's a good indication that you're not solely dealing with the hip and more related to some kind of nerve impingement, oftentimes from the back. Those patients with radiculopathy oftentimes will have at L4 to S1 will have a positive straight leg raise test, and it's been documented that up to about 60% of patients will have a positive straight leg raise test with a radiculopathy. So moving on to spinal stenosis, this is basically when the spinal canal is decreased, right, for a number of reasons, but it's oftentimes related to, associated with age-related changes, right, facet degeneration, disc degeneration, osteophytes, and other more chronic degenerative conditions can oftentimes cause back pain, but also buttock pain. This patient population, in comparison to a radiculopathy, will have more neurogenic type of symptoms, so they can oftentimes tell you the distance they can walk and then they have to sit down. But sitting down makes it feel better. Bending over, a lot of times you'll see people hunched over at their low back when they walk. That's typical of a stenotic picture as well. All right, so SI joint pathology. These people have buttock pain that's non-radiating. And a lot of times they will specifically point right to the back of the SI joint or the sacrum. And again, like I had mentioned, sacral stress fractures can present very similarly to this, except a little more dramatic. Sacral stress fractures, they have trouble putting weight on their leg, whereas SI joint arthritis or inflammation patients usually can, but typically a physical exam, right, the Faber test, that's flexion, abduction, and external rotation of the leg, will put some stress on the SI joint and oftentimes cause pain for them. But it can be difficult to diagnose, and a lot of times the best way is have somebody like Dr. Thompson get a fluoro image and put some lidocaine in there, and that's probably the best way to really know for sure if you're dealing with a sole SI joint pathology, is that can oftentimes take the pain away. And conversely, in a sacral fracture, it shouldn't, right? That's separated from the capsular SI joint, and those patients should continue to have pain. And then finally, the external rotators, piriformis syndrome. These patients have trouble sitting. They have pain when they sit. Their pain is really deep. It's near the sciatic notch of the buttock. But they can also show signs of radiating pain that actually goes down the leg. And a lot of that is from tight external rotators that pinch the sciatic nerve and cause similar radicular symptoms like you would in the low back. I like doing an external rotator stress test. I like doing this prone and externally rotating the leg. It's probably not the best way to stress the external rotators. That's going to be more with flexion and internal rotation. But the problem with that is deciphering between people who have impingement and a piriformis syndrome, because that's the maneuver of a hip impingement test as well. So the differentiating factor there would be, it would be more posterior pain compared to, with hip impingement, it's going to be more anterior pain. All right, and the big disclaimer, right, is it's an algorithm. It's not foolproof. Not everything falls into this algorithm. It's trying to get a nice, organized way to treat a confusing subject. An L1, L2 radiculopathy, which we have all had, come in and say, my hip hurts, and they have groin pain. And they have normal x-rays, and you get an MRI, and oftentimes it's related to a radiculopathy. It's not common, but it's there. And conversely, right, posterior buttock pain, patients who are arthritic can have buttock pain. It's not the typical presentation, but it's certainly very possible. And then lastly, right, the talk of an MRI, and really who should be ordering this test is the treating orthopedic surgeon for a number of reasons. But a lot of times these things can be diagnosed with a good physical exam, history, and x-ray. But like I had mentioned throughout my talk, there are some that really do need an MRI to help you with the diagnosis as well as with treatment in the case of AVN. But nonetheless, a lot of MRIs are unnecessary, so leaving it up to us oftentimes can be cost-effective, as well as it decreases the amount of incidental findings that you will see on an MRI. A 75-year-old lady with arthritis who has a little, or not arthritis, but bursitis, who has a little labral tear and has no signs of intra-articular hip pain. Patients can really get hung up on labral tear. That sounds pretty bad, right? When you know well that that's just not what your problem is, but it can be confusing, and all the more reason to try to leave that up to us. All right, thank you.